Hi everyone. Hi everyone. First, I'm thankful that I'm here. It's a great pleasure to be with you all. Today we are going to ask the experts the last question, the residual risk. How can we start the fight? First, as an introduction, we should know that the burden of cardiovascular disease is huge. About 4% of the total world population are suffering from one or more form of cardiovascular disease. And this translates into about 300 million persons. This leads to about 300,000 deaths each week. And despite the fact that we have did a very good job in prescription of good secondary preventive measures, still cardiovascular events are recurrent despite care, despite statins, despite aspirin, despite different drugs and even lifestyle. Suffice to know that about 5 to 10% of those patients who have suffered already an atherosclerotic cardiovascular disease still are prone to a recurrent event within the upcoming 4 or 5 years. So we are in front of what we could call a non-formidable enemy. And it becomes a very legitimate question, which residual risk we are facing. As a starting point for the discussion, look to this hypothetical example published recently in the European Heart Journal. If you have a person with a known cardiovascular disease and his or her LDL is about 150 and his high sensitive CRP is high at 4.5, and you gave this patient a high intensity statin as Dr. Said said, you have two possibilities. The patient could obtain his LDL cholesterol goal and still his or her high sensitive CRP is high, so you are in front of a residual inflammatory risk. On the other hand, the patient could attain his high sensitive CRP goal, but still his or her LDL is high. So in this case, you are in front of a residual cholesterol risk. So 3 questions are up. The question number 1 to our experts: what are the causes of this residual risk? Is it the metabolic? Is it inflammatory? Is it thrombotic? Number 2, how can we fight this enemy? And finally, what's the evidence behind the tools in our hands today? I'll leave about 6 minutes for our experts for discussion, and I'd like to start by Professor Atif Al-Bahri.
I suggest, Professor Atif, each one of you experts mention one cause of the residual risk and how to tackle it.
Unexpected, I will let all the others for my dear colleagues. First, we don't reach the goals with LDL, and this is a residual risk before saying anything inflammatory or triglyceride or blah blah. Residual risk is still the LDL, which has no number to go and to give us the optimum prevention.
The second cause I think to be is the elevated high sensitive C-reactive protein with normal or with target LDL.
Inflammation.
I do believe that you will mention study for normal LDL or guided LDL with high sensitive C-reactive protein, how it benefits from.
Dr. Aouni?
So we have here the metabolic residual risk in terms of non-reached LDL goal, which are lipid, and the inflammatory residual risk. We would like to hear your opinion. Is it thrombotic?
Yes, thrombotic is one of the risks, like metabolic and inflammatory. Even in patients reaching the target lipid level, there is still remaining risk. Some studies mention that even patients with high intensity statin therapy has adverse cardiovascular events reaching up to 9% within 5 years. I think in PROVIT trial, after 7 years follow-up, it showed about 1/3 of the patients developed.
Mike.
Even in patients reaching the target, there is still residual risk. So we should attack all the 3 factors: thrombotic, inflammatory, and metabolic.
Yes.
So, Bendary, we have inappropriate lipid management. we have inflammation, and we have thrombosis. All of these can lead to residual risk despite our treatment. How can you treat each one?
Yes. Thank you very much, my professors, for these excellent inputs. And now to the summary of all what have been said. First, if we ask it a very simple question, what makes plaques larger? You will see that we are evolving around three pathophysiological processes. Number one, the metabolic, denoted by the LDL cholesterol and non-HDL cholesterol in addition to insulin resistance. Also, we are evolving around the thrombotic residual risk, the hallmark of which is, of course, endothelial dysfunction. And finally, the hallmark of the inflammatory residual risk, which is high sensitive CRP. But it appears that triglycerides have a rule. Look with me to this important paper published in JACC just a few months ago. This paper categorized patients according to their LDL cholesterol into those patients who did not achieve the LDL cholesterol and the patients who succeeded to reach too low levels of LDL. And in both categories, it appeared that we have a graded response between the numbers of vascular territories affected by atherosclerosis and the percent of subjects, which in other words mean that despite control of LDL, the triglycerides appear to be playing a role in this residual risk. And if we looked into this important paper published recently in European Heart Journal in 2016, comprising data from IMPROVE-IT trial, which tested the addition of ezetimibe to statins compared to statins alone, and the PROVE-IT trial, which tested the strategy of high-intensity statin lipid-lowering therapy to standard lipid-lowering therapy in patients post-ACS. This paper categorized patients into four major groups: those patients who attained their LDL cholesterol only, those patients who attained their high-sensitive CRP goal only, those patients who did not attain neither targets, and those patients who succeeded to achieve both targets. And if you can see the red line, those patients who succeeded to achieve both lipid and inflammatory targets enjoyed a significantly higher event-free survival compared to those patients, of course, who did not achieve any target, and those patients who achieved only one single target of both. So we are in front of three main types of residual cardiovascular risk. First is the inflammatory residual risk. Second is the residual metabolic risk. And finally, please, friends, don't forget the residual thrombotic risk. First, how can we target the inflammatory residual risk? Look with me to these important three major trials. The Jupiter trial, which tested the addition of rosuvastatin compared to placebo in apparently healthy males and females with LDL of average 130 and high-sensitive CRP. This trial provided the benefit of rosuvastatin in terms of reduction of fatal and non-fatal MACE in those populations. In the middle is the CANTOS trial, which tested the addition of canakinumab, which is a monoclonal antibody to interleukin-1b in patients post-acute myocardial infarction with high-sensitive CRP more than 2 milligrams per deciliter, again, a positive trial. And finally, recently, do you remember the COLCO trial, which tested the addition of colchicine, a purely anti-inflammatory molecule, in patients post-acute myocardial infarction with high-sensitive CRP? Colchicine 0.5 milligram resulted in a significant reduction of fatal and non-fatal vascular and peripheral vascular events. But how can we target the metabolic risk? Of course, we have the high-intensity lipid-lowering therapy, and we have now tools, the PCSK9-based therapies with their PCSK9 monoclonal antibodies and also the siRNA. But please don't forget the risk factor of diabetes. And don't forget those molecules, the SGLT2 inhibitors and GLP-1 receptor agonists. And now you are allowed to prescribe SGLT2 inhibitors in non-diabetic patients with heart failure and chronic kidney disease. Across all trials, these molecules resulted in a significant reduction of the 3-point MACE, in addition to a consistent, astonishing reduction in the future risk for hospitalization due to heart failure and a decline in the rate of the GFR deterioration. And also, I should mention the icosapent ethyl, which in reduced trial resulted in a significant 25% reduction in the primary endpoint in diabetic patients who had another additional risk factor whose triglycerides did not control despite maximum tolerated statin therapy. This is important and indirectly denotes that triglycerides might be playing a role as a residual risk in those populations. And finally, again, don't forget the thrombotic risk. Who could forget the COMBAS trial? This major trial, which comprised more than 27,000 patients with a stable cardiac and peripheral vascular disease, and randomized them between receiving rivaroxaban 2.5 twice daily in addition to aspirin, aspirin alone, and rivaroxaban 5 milligram twice daily. And in this trial, the COMBAS trial, those populations that were randomized to receive rivaroxaban 2.5 twice daily in addition to aspirin enjoyed a significantly better long-term outcome compared to the other two groups. And also, we have the Pegasus 54 trial, which randomized patients who had recent MI 1 to 3 years ago to ticagrelor 60 milligram twice daily, ticagrelor 90 milligram twice daily in addition to aspirin, and it appeared in this trial that extending the dose of ticagrelor beyond the first year could provide a benefit, and the sweet spot was for ticagrelor 60 milligram twice daily. So I have finished my lecture. I hope you enjoyed the session. Thank you and goodbye.